Good morning. We should get started. So I'm here to cover for you the foundation knowledge of parasitology. And I think Dr. Finowell will take care of the clinical case and more in the line of clinical aspect. So during my presentation, if you have any question, don't hesitate to ask. And you can also send me an email, call me, come to my office. If you have any question at all, I will be enthusiastic in helping you to understand the foundation knowledge of parasitology. That's what I'm here for. So several years back, I reorganized the study guide and to include the 7 items on the board, from transmission to prevention. So this is really done for to be in line with the other part of the study guide. But for parasitology, many of these are really not known or it's not available. For example, for the prevention, there's no vaccine available for any of the parasitic diseases. If there's something available, they are not really working well. And we really don't know a whole lot about pathogenesis, how they cause diseases. So the emphasis is going to be somewhat different. And I will cover the area where I think we know more. And you probably want to know. So in the process, any questions surface, do raise your hand or just shout out and I will help you. I think I saw you just once last year about the skin parasite. And I say the same thing. And I don't think anybody really has that much interest in parasitology in coming to me. Just in case you have more interest in the subsequent material we are going to cover, do let me know. So some of these things I'm not going to mention. I may mention in passing, but we really don't know a whole lot, okay? And so what we are going to cover are 2 different groups of parasite. And by tradition, parasitology include these 2 groups, protozoa and helminths. These are eukaryotic microorganisms. In fact, the helminths are the worms, which are multicellular. So you can imagine on that foundation, they differ a lot from viruses, bacteria, and so on and so forth. So I think it's important to keep that in mind in considering their clinical diseases and also for diagnosis, prevention, and so on and so forth. So we are only going to cover 6 different species of the parasite. The first 3 are protozoa. These are single-cell eukaryotic microorganisms, and the last 3 are the worms or the helminths. So this is going to be introduced to you individually, one by one. So the first group include Entamoeba histolytica, Giardia, Lamblia, and Cryptosporidium. These are all intestinal parasites, but with a different clinical outcome, which we're going to discuss. But I'll just point out very briefly in the beginning, Entamoeba has a tissue phase infection, can get in the liver and other organ. Giardia is more limited to the intestinal disorder, and crypto is also intestinal, but they could have more profound impact on the immunocompromised individual, and also epidemiologically they can be a problem when you have some kind of outbreak due to the water pipe breakdown. So Entamoeba histolytica can cause amoebiasis. And the focus here is going to be in the life cycle as true for most of parasitic infection. If you understand the life cycle, you can have a better idea about their pathology and also the material needed to make the diagnosis. So we acquire this infection by eating and drinking. There's a cyst which are resistant, so they can survive outside in the environment for a long time. And once they get into the intestinal tract, the majority of the patients is going to experience nothing at all, or in some cases can be GI disorder, and so there are clinical aspects which are different from the others, and that's going to be pointed out later on. So as I mentioned earlier, in this case, the amoeba can come out into the tissue and causing other problems. So in the intestinal tract, they undergo so-called excistation. So this is a cyst, and they come out into this stage called the trophozoa, which is the stage undergoing replication and causing all the problems. So during this period of parasitism, from time to time, they undergo this encystation, so they will produce cyst again. And this cyst will pass out, and which is the foundation of the stool examination for making diagnosis. So the general distribution is mainly in the tropical, subtropical area. If you visit Mexico or other developing country, you need to pay attention because of the spread of this disease is common. And reservoir animal is always important. In this case, other primate may be a reservoir, but it's not sure. The infection mainly occur in human. So the clinical manifestation I already mentioned, dysentery, and they have bloody mucoidal stool with abdominal pain. And if you have the section examined, you'll find this flask-shaped lesion. It's all because of the parasite activity, creating inflammatory response, and so on and so forth. And the picture at the bottom shows the liver abscess, which is due to the invasion of amoeba. They come out of the intestinal tract and invading liver. At the same time, they could also create a pulmonary or cerebral amoebiasis, but when they move out of their usual habitat of the intestinal tract, end up in the brain or in the lung. So this is the more unique feature for this particular disease. The risk factors is poor sanitation, you are not careful with your eating, and accidentally taking in the cyst. The virulence factors are related to their surface structure, there's some enzyme released, and for diagnosis, as most of parasitic diseases, in most locations, it still depends on microscopic examination of the parasite, in this case, in the stool. That's true for all the GI parasitic diseases. You find the structure, the reason is very simple. This is not like virus or bacteria. They're morphologically all the same, but in this case, they have a specific structure you can actually visualize, especially after staining. So all these molecular immunological methods are not really being practiced in the sense of a wide application. There may be specific, but in most clinic in the endemic area, they still rely on microscopy. So how do you make diagnosis? For most of these parasitic diseases, the travel history is important, and the clinical manifestation is usually relied upon to make diagnosis. Then you send your sample to the lab and to confirm. And so their treatment, if you don't have clinical manifestation, you use different drug and prevention or diminution. You just have to be careful, avoiding drinking tainted water or food. Any questions? Is this okay with you? Okay, so if you have any question, let me know. So the second one we want to talk a little bit is Giardia, giardiasis. This is more limited to the intestinal tract. So here is the life cycle, how you acquire this, and you can acquire this through eating, and anal sex can give you this problem. So these are all the material which may be contaminated with the cyst. If you take those contaminated material, the cyst will end up in the intestinal tract. So here is the simple life cycle. You can see the cyst will go through this exit station, and they give you this trophozoite stage. That's basically the vegetative stage. That's the active, metabolically very active stage, which can undergo the cell division. So Giardia is very structurally unique, as you can see here, and we'll show you some picture. So during the process, they undergo encystation, and this is the stage which will pass out, contaminating the environment, the foodstuff. So this is the foundation of the transmission cycle. So here is a picture I was mentioning. With trophozoa, you have 2 nuclei and 4 pairs of flagellum. So they have a certain motility. And the cyst have 4 nuclei with a thick wall. And if in the diagnostic lab, if you have the trouble, they can use spatial scan to outline this flagellum, so the structure can be visualized more readily. So in Giardia, it's non-inflammatory diarrhea cases, and sometimes they can come up with acute phase. That's take place within a month. If it's over a month after you travel to somewhere, you ingested the cyst, it may not come up in a short time, and then you call this chronic phase. Otherwise, the clinical manifestations are more or less the same. You have this greasy stool, they tend to float, and flatulence, and bad smelling. Whether it's acute or chronic, they are all the same. The virulence factor has been under study by some research lab. They are known to undergo antigenic changes, variation of the surface, and this can escape the immune attack. And as in many other protozoa, they have a surface structure which are important to protect themselves. They release the enzyme, and that can create problem when they interact with the epithelial cells. So this is a picture I throw in there just to remind me to mention giardiasis is zoonosis. So you have other animal which can be infected as a reservoir to create the cyst. And as a consequence of this, they are hard to control. And the diagnosis, as I already mentioned, this is mainly based on the clinical sign and the travel history. So in this case, you could have a vague, start out with a vague, with abdominal cramps, and this can persist even after treatment, and increasingly severe, and then you have diarrhea and other manifestation of the clinical symptom. The diagnosis is to visualize by stool examination the cyst, which differ in morphology from the trophozoite, which can also be observed in the stool. I think I want to show this again. I forgot to mention here. So if you look at this structure, you can see the one side of the protozoa is flattened, which is the side that here to the epithelial, gut epithelium, and creating the problem. So the differential diagnosis versus amoebiasis, bacteria, dysentery. So in the case of Giardia, there's no mucus, no bloody material or PMN, and the treatment is the usual drugs, including metronidazole. Prevention is mainly based on your personal hygiene and careful, not to be careful with what you eat and drink. And from the public health point of view, you need to take care of the sewer system and to avoid the contamination with the cyst. So the last one, yes. So for example, in the Eastern European country, the problem is really the running water. Their sanitation may not be that great, so you get this infection from the water. And in the more tropical, subtropical, the things is in the environment. So improper disposal of the human waste is probably a major cause there. So you have the spore contamination, say in the environment, in the soil here and there, and they get into the food and your drink. So I don't know if I answered your question. Okay, anything else? So you notice the difference between amoebiasis, giardiasis. So these are very different diseases, but the diagnosis is always the same. You examine the stool, looking for their typical cyst morphology. So this is cryptosporidiosis. It's caused by Cryptosporidium problem. And so before I go any further, I just want to say this is a very complicated life cycle. You don't have to know And in terms of transmission, it's basically the same. You have spore in the environment, and then you ingest this unknowingly. These are microscopic, even though they are bigger than bacteria, so you're not going to notice them. So you take this in, then in the intestinal tract, they undergo all these changes. They have sexual stages, asexual stages. Then they have this, in the end, they have a sporulation, creating the resistant spore. And these are the form, pass out, contaminating the environment. And then if your environment full of these cysts, they are easily contaminating your food material, your drink, and even the surface of the desk or wherever. And you pick this up and put it into your mouth, then you get this disease. The other terminology is the same as the others, trophozoites. These are the form. In the red environment of the intestinal tract, they will change from the spore into trophozoa. This is so-called the metabolic active trophozoa stage, and undergo cell division and causing bulk of the problem in the GI. And this is pass out, as I already mentioned, contaminating environment, creating the problem. So there are certain details in your study guide. You can go over that, and it's watery, diarrhea. So the feature of this cryptosporidiosis include two different aspects. One is it tend to be a community problem when you have water pipe breakdown, and then they get contaminated. So the whole community, as a result, can suffer from this kind of outbreak. And the HIV population with emerging AIDS epidemics, you have this immunosuppressed individual can become more susceptible to this infection. So the other material are pretty much the same. Diagnosis by microscopy. Prevention is based on community public health effort to make the environment, water supply, food supply clean. And the picture here shows you the oocyst, which is the spore I mentioned to you, are taken in, and they will change into trophozoa, and they have a special stand, as I pointed out. Sometimes stool examination needs to be treated especially in order to see the material among all the debris, and there are special stand you can use to review this particular species. So these are the only three we cover. Any questions you have? If not, we'll move into parasitic helminths. Just refresh your memory. The helminths is a very diverse multicellular organism, and basically divided into two different forms. One is a roundworm, also known as nematodes, and the other is the flatworm, include two subtypes. One is the tapeworms. These are segmented worms. It can be very long, or the flukes, like leeches, also known as the cestodes and trematodes. So helminthology is a very big topic, and there are hundreds of thousands of different species. Many of these, especially nematodes, is actually living in the soil, and they are important agriculturally to make the soil suitable for plant growth. So nematodes are not always the bad guys, and many of them are important in agriculture. And the tapeworms, majority are parasite. I don't know of any free-living tapeworms. And most of these are in domestic animal, and they can be very, very long. It's incredible in length. And the trematodes are also diverse, and many of these are parasite of animals. So what we are going to say next is their biological properties. I think this needs to be mentioned in order to differentiate this from protozoa and from all the other single-cell pathogens. As I stressed repeatedly, these are multicellular organisms, so they have a differentiation. And the life cycle includes the eggs, also known as the ova, and the young worm, known as the larvae, and the adult can be male or female. And the common feature of these helminths, especially the parasitic species, is the enormous capacity of reproduction. So each female worm can release thousands of eggs or hundreds of thousands of eggs per day, and in order to survive. So they have a different way to undergo reproduction, including the usual male and female, two different sex individual. They have hermaphroditic, and the way they produce young include egg laying. They lay a lot of eggs which will hatch. Sometimes the egg will hatch inside the female, and this is called viviparous. And when they come out, they are larvae. They are young worm already. And the transmission, many of these species are transmitted by vectors, including insects, and they have their life cycle may involve more than one host. So you have intermediate host, defensive host. I think these were defined in the introductory paragraph. So are there any questions about the helminths? I'm just trying to give you some idea to shift your thinking from virus to bacteria to protozoa, now to these helminths. Okay, so we are going to talk about three, but in reality there are many other parasitic helminths. If you have interest, you can read the parasitology textbook. So the three species we're going to cover: Ascaris, Strongyloides, Trichuris, and these are probably the most common, and one of the three is most important in terms of the disease severity. So the Ascaris, all of these are taken in through the mouth, except the second one, and it is caused by skin penetration by the infective larval stage. And so this is the oddity of a parasite. You remember I talked about the skin infection. Many of the parasites can get into skin, but they don't necessarily cause skin diseases locally. And I give you one example in the skin parasite. The pathology is in the skin, but actually the worm, the parasite live in the intestinal tract. So here is another example. You have skin penetration, but in the end they end up in the intestinal tract. Okay, so these are some of the examples to give you the representative scenario of infection and disease. And the infection does not always cause diseases, as should have been pointing out in the introductory. And this is a good example in the case of parasitic helminths. You could have infection and there's no disease manifestation. So the ascariasis, also known as intestinal roundworm, caused by Ascaris. That's all the name you need to remember, because we only talk about one species. And this can be long, usually several meters, but it can be as long as 12 meters in your intestinal tract. But if you have only a single worm, you don't know anything. You don't know you have the infection, even if you have a dozen or more. It's really innocuous infection on the whole until you get a heavy burden. So the transmission, again, is accidental ingestion or unknowingly ingesting fertilized eggs. And as I mentioned earlier, each female worm can release 100,000 eggs, but not all of them are fertilized. So only the fertilized eggs can cause disease. So this is taken in with your eating, drinking into the intestinal tract. So here is the RDT again. They end up in the intestinal tract. They don't stay there. They hatch into the young stage, the larvae, the first stage larvae. They penetrate mucosa. Then they enter into so-called tissue migration phase. So where they end up in the lung, and they move up through the trachea, and then you swallow back in through the esophagus, back into the intestinal tract. So you can ask question why the worm wants to do this. It is the interesting issue. Nobody really knows. They need to go through this kind of migration in order to have the right environment for them to go further into the adult worm. If you just put them, the first stage larvae, put them into the intestinal tract, they will die. They need to go through this process. Okay, so in the intestinal tract, during the tissue phase, there are certain clinical manifestations. We'll talk about that. The intestinal residence phase, as I already pointed out, is relatively innocuous, unless you're full of this ascaris worm in your intestinal tract, then it can be blocking the passage, and then you may have trouble. So the life cycle is very simple. Aside from this tissue migration phase, male and female in the intestinal tract, they mate and produce eggs, and these eggs pass out through defecation, contaminating the environment. If you don't treat your waste, human waste, properly, if you have a flash toilet, you have less of this problem or no such problem at all. And so these are the different eggs form I mentioned. And so the central feature of this egg is they are heavily coated, so they can survive in the environment for a very long time, up to 3 months or so. So during this time, they are still viable and can produce problems if you ingest them. So the next several slides just give you some idea about the appearance of this worm. And so you can see they are pretty robust. And the male and female are separate in this particular species. And what you see here is a cross-section of the worm, again, to give you some idea what is the internal structure. Bulk of structure you see here are reproductive organ, and which is the reason they can produce hundreds of thousands of eggs on a daily basis. And the GI is relatively inconspicuous. A lot of the worm will take up the nutrients through their skin. Although they have a particular structure to protect themselves, the stuff can still come in. And below that is endothelial cells. The remaining material you see are the ground substances. So this is the worm structure, as you can see in the cross section. So the picture you see here is the egg, and these are heavily protected by certain material resistant, can prevent evaporation, so they the cell inside can survive for that long, for 3 months. And this is the major item important for diagnosis. You do the stool examination, you find this, and you have your diagnosis. So I already mentioned the clinical symptom is very mild or nothing at all, and except during the tissue migration phase, even there is very innocuous. You may, as worm migrate, you may have a general feeling of weakness, and they end up in the lung. You might have pneumonitis, but these are hardly noticeable. You may cough, have some sputum, and you thought you might have a flu or something, and then they migrate through the trachea, as shown here in section. So these are profile of the young stage. This may be one worm cut in different angle, and then they migrate into the trachea, coming back through esophagus, and then end up in the intestinal tract. So if you have hundreds of worms, you may be in trouble because it's too crowded. And then they will move to other locations like the cecum. Then you have this inflammatory, you may need to undergo surgery. If your intestinal tract is blocked by dozens of worms or hundreds of worms, you may have to undergo surgery to remove them. But that's very rare. And so I might want to point out at this point, at this particular juncture, you ingest one egg, give you one worm, right? So the worm itself is not going to replicate. This is the major difference between virus, bacteria, protozoa from helminth. So if you end up with dozens of worms in your intestinal tract, you must ingest that many fertilized eggs to give you a single worm. So this is understood, right? So they don't replicate. The replication is based on egg laying and contaminating the environment. Okay, so Ascaris is a very old parasite. It's found in the mummy, Egyptian mummy, thousands of years ago. You find the eggs, they're calcified. You still can recognize them. So this is a parasite probably associated with the human for as long as we emerge on the earth. And as a result, they learn to live with each other and not creating too much problem. Risk factor or dimension, virulence factor is not known because they don't create too much pathology in the first place. Treatment is the usual one, and I already mentioned you may have to undergo surgery if they block your intestinal tract. The rest is the same thing. You have to pay attention to your personal hygiene. You go to the endemic area, and the community needs to take care of their feces properly so you can avoid the contamination of the eggs. Any question about this helminth? Okay, then we'll cover the second one, is known as the intestinal threadworm infection caused by Strongyloides. And this is probably the most serious intestinal helminth we know. In the life cycle, as shown here, is complicated, but let me break this down so you can understand. The infection started out, as I mentioned, by infective larvae. They penetrate the skin. Then they end up in the lymphatic or blood system. Then they undergo the same migration route as I mentioned in the Ascaris. So they end up in the lung and move up in trachea, come down through esophagus, eventually end up in the intestinal tract, where they will mature into male and female worm. And then they mate, they produce eggs. So the complication you see here about their life cycle is related to their egg laying as well as the hatching of the eggs. So in most cases, for example, in the ascaris, the eggs are laid, and then you need to ingest, they will hatch. But in this case, the egg laid by the female worm can hatch while they are still inside the intestinal tract, or as they pass out, hatch on the skin. So what is the problem with this? The problem with this is very simple. That means if you take this patient away from the site of infection, put in the hospital, if you don't make a good diagnosis, you don't know this is the cause of disease, the parasite burden can increase. This is related to what I mentioned to you earlier. One fertilized egg give you one worm. So if you have a repeated penetration by this larvae, you're going to have increased the burden of the parasite, and this is the parasite far more antigenic in the bad way than ascaris. So consequently, if you don't treat, the parasite number is going to increase, and then you can have a antigenic shock, and the patient can die. So this is the only known intestinal helminth infection which can cause fatal incidences. So this is so-called hyperinfection or superinfection. Okay, so there are two unique features. One is penetration by infective larvae, but instead of ingesting the eggs. And the second one is the egg can hatch while they are still in the host. And the last one cycle here is referred to as the free living cycle. That means the infective larvae, if they cannot find a host to penetrate, but they can survive in your intestinal tract, they will continue to survive as a free living organism in the soil. So that means they will change into male and female worm. They will mate and giving you the eggs, and that can hatch and periodically generating the infective larvae, and this can penetrate human skin. So where do you find all this? Mainly in the tropical, subtropical area with high humidity. So this free living cycle can persist, and the eggs can hatch. So more specifically, this is in the plantation, cocoa plantation, banana, coffee, and so on and so forth. So the worker don't wear shoes. They work, and then they can easily get skin penetration by this. So all this seems to be extraordinary, but not to the local farmer. They don't wear shoes, whether they can afford it or not. And you will see later on, in the case of schistosomiasis, it's also caused by skin penetration. And for us, it's very easy to understand. Why don't you wear shoes? Then you'll be free of infection. It's easier to say than done. So I already covered all of this, skin penetration and so on and so forth. So the distribution should be obvious to you. This is in the high humidity, warm weather places. The reservoir is not known except human. So this is a human parasite. The picture you see here is the free living larvae in the soil. So based on the life cycle, it should be clear to you the clinical manifestation, first involving the skin inflammation when the infective larvae penetrate the skin. But this is relatively minor. And then once they get into skin, as you see in this picture, the adult worm, well, they go through this tissue phase migration. So you have a minor tissue phase illness and a lung infection, very minor. But once they get into the intestinal tract, they become adult worm. then they tend to probe into the mucosal layer, and this can cause intestinal disorder. But none of this is really very serious until you have this hyperinfection scenario. So you build up your worm burden, then the antigen released by the worm can cause antigenic shock, and the patient die in your hand. Okay, so risk factor is obvious to you. Virulence factor is not known. Diagnosis is based on microscopic examination of stool as the principal way. And the treatment, the usual antihelminthic prevention is based on your awareness of this disease and avoiding your exposure. Community-wise, you have to take care of your public health. So this is summary. I already mentioned this in the presentation. The eggs pass out, hatch in the moist soil. Is the principal way of infection. These infected larvae will penetrate your skin to cause infection. Then you have free living cycle, I mentioned. And most important is the hyper-autoinfection. The same patient keep getting infection from the hatched egg into infected larvae, and then you have antigenic shock to death of your patient. Okay, so this is the second one. The last one is called GIparasites caused by trichuris. So this is the intentional whipworm infection. This is very mild infection unless you have a heavy parasite burden. So the life cycle is very simple. Normal tissue phase. You accidentally ingest the fertilized egg. They end up in the intestinal tract. Then usually near the colon, where you have a male and female producing egg coming out in the contaminated environment. So distribution is worldwide, temperate and tropical area. They all have, if you don't have a good sanitation. So this is the appearance of the adult worm. You can see the interior end is very thin. It's very, very robust and stiff. And so this is a preserved material. If you look at the fresh material, you can see only the fatter part of the worm body, the thin part inserted into the mucosa. And this is the cause of the major problem when they end up in the colon, where they prefer to stay. Then when the worm burden is high, you have dropping out of the anus, and that can be very painful. So here is the picture. You can see this anal prolapse. You have too many parasites infecting the epithelial cells near the intestinal tract, near the anus. Then they drop out. If you look at the blow-up picture, you can see the worm with their anterior end sticking into the mucosa. Diagnosis is based on the eggs. And this eggs morphology is important. You see the morphology of the Ascaris egg. They are wrinkled and rough and thick. So in this case, you have this bipolar caps. So this is a diagnostic feature based on the morphology of the egg. Treatment is the usual thing. You could have supplemental, supportive, nutritional support, and so on and so forth. So preventing people from other manifestation of anemia and so on and so forth. Okay, so the prevention is the usual as the others. So we cover 3 parasitic helminths. Ascaris, pretty innocuous, unless parasite burden becomes extremely high. Then you have intestinal obstruction. Then you have problem, or they migrate to somewhere else. And the trichuris, can give you anal prolapse. That can be a big problem, very painful. It's not fatal, but in the case of strongyloides, it can be fatal if you don't take care of the patients, and they can have a shock to death. Okay, so any question about Hellman's?
Let's try one quick case. 20-year-old male student presents with a 2-week history of crampy right lower quadrant, plain and bloody diarrhea, low-grade fevers, and complaints of anorexia and weight loss of around 8 pounds. Denies nausea or vomiting. The patient recently returned 4 weeks ago from a spring vacation, sounds like fun, in Belize, and admits to being careless about food and water. Temp is up at 38, his pulse is at the upper end of normal, respirations and blood pressure are fine. He's okay in general. The only thing that's different on the physical exam is mild right lower quadrant tenderness without guarding a rebound. His white blood cell count is normal, liver function is normal, stool is positive for all-cause blood. We do a direct exam of the stool and see this characteristic shape pointed out to us by the arrow. So what kind of diarrhea is this? Oh, phooey. Okay, we'll have to stop here. I can't reload it in time. It's, of course, acute inflammatory diarrhea. And what's the disease he has? Shout it out. Entamoeba. That's an entamoeba cyst. Okay. Let's see. Okay. It's inflammatory diarrhea. The most likely agent is entamoeba. Sorry. Okay. Okay, so we'll take a break now for 9 minutes, and then we'll come back. The cases will be there. I'll assemble all the cases for the GI system, and let's come back at 10 o'clock, and we'll hear about more GI bugs. Rats, I'm sorry it broke down.